Hello. If you're ready to go, Dr. Fox, I can give you an introduction.
Oh yeah, I'm ready.
All right. Welcome everyone. Today we have Dr. Nicole Fox, who will be presenting for us. She is board certified in psychiatry and lifestyle medicine, and also has a master's in public administration. She went to medical school and residency at University of Washington and is now one of our faculty members. And serves as the Associate System Medical Director for Behavioral Health for St. Luke's, and clinically works on the consult service, and was actually one of the founding members of the behavioral health service line at St. Luke's. And we have appreciated her very much as an educator within our residency program. And last year she was nationally recognized with the Irma Bland Award by the APA for her excellence in resident education. And she's a fellow of the APA. So welcome, and I'll let you take it away from here.
All right, thank you. Can you hear me okay? I borrowed someone's headset and it's just very disorienting. Everyone can hear me okay? Okay, I'm gonna actually probably hide this little thing so I can't see all of you. So someone will have to speak up if something is going wrong. Well, welcome to Grand Rounds. I'm going to talk about psychedelics and psychiatry. This is a reprise of a talk I gave at the IPA last year. So if you already saw it or heard this talk, then sometimes it's good to hear the same thing twice, helps it sink in. Otherwise, I hope you enjoy this journey. It's a really interesting topic, I think, psychedelics and psychiatry. This topic is, really taking the national stage and has so for the past few years. So we'll just jump right in. And this talk is, not really meant to be that controversial. It's not meant to persuade you that you should start prescribing things differently. And in fact, the things that we're going to talk about, by and large, aren't prescribable yet. So it's just to help you know about the conversation, help you really become more aware of the psychedelics, what they are, what the studies are looking into in their use. You will not come away from this talk knowing how to prescribe any of these substances, but you'll become familiar with sort of the sordid details of the history of the development and the cessation of development and the resurgence that's happening, along with the basics of the different psychedelics in question. So I don't have any disclosures. These are just really pretty pictures of the psychedelics that we'll talk about to some extent, not all of them. The first thing you see is ayahuasca. That's a tea that can be brewed. The next thing that looks like Smarties are they're MDMA tablets. They're used to be a party drug, still is a party drug in certain circles, raves and that sort of thing. But as you can see, they seem to be especially made to look like candy for that kind of party scene. The next picture is of salvia. You may have this growing in your yard. I'm not really sure. It's a very pretty plant, and these leaves can be chewed for psychedelic properties. I don't recommend it. I don't know if this is the type of salvia you have in your yard, but I wouldn't recommend going to Home Depot and trying it out. You might end up with a very different day than you expected. And then the last picture is our psilocybin mushrooms, magic mushrooms. These occur naturally, throughout North and South America. So there you go. So I'll just start with a little bit quote from Aldous Huxley. And I'll tell you that Aldous Huxley, I'm sure many of you read Brave New World in junior high. Show of hands who read Brave New World. And anyone obsessed with kind of dystopian society at that age? I personally was, after reading Aldous Huxley and some other dystopian authors. But Aldous Huxley was given LSD, actually, by a friend, and he experienced this as what you would call a trip. And he wrote a book, Doors of Perception, based on his experience. And here's what he had to say about that experience. And he was really ahead of his time in conceptualizing what is starting to be understood as true in research of the potential therapeutic uses of these substances. So again, this was after ingesting LSD from a friend who was actually a clinician and sort of testing it out. What we ordinarily call reality is merely that slice of total fact, which are biological equipment, our linguistic heritage, and our social conventions of thought and feeling make it possible for us to apprehend. So here he's using the word apprehend as to understand or perceive. Does anyone have any sense? You can just drop in the chat of what he really means by this. What we ordinarily call reality, so the reality we all share, is really just a combination of our biology, our linguistics, and kind of the social conventions, and how those things come together allow us to perceive. And so I can't see the chat, so I'm just going to hope that someone's putting their thoughts in about Aldous Huxley and what he had to say about his experience with LSD and the doors of perception, which he found to be open. And when I said that he was really onto something, what I really mean to say is that there's an idea that the way psychedelics work is by loosening, in some ways, we have increased connections in our neurons, have increased connectivity, but there is this loosening of what we might think of as automatic thoughts, or even some people might call stuck points. And so that if we have a loosening of what automatically we conceptualize as reality, then we might actually be able to have alternative explanations of the world and how we experience it. So that's a little bit there. So what are we going to talk about today? Now that sets a little bit of the framework. And oh, I should let you know that I did rearrange the slides a little bit from what I sent Heather. She has a PDF that she's going to send out, but if you prefer it in the order today, it's not really a massive rearrangement. I typically go back and forth between how I'd like my slides to come out. So if I can resend it if that's important to everyone to have them in the exact order. I don't think it actually has any material difference. So today we'll talk about, I'll give you some brief definitions of what in the world do I even mean when I say psychedelics. For a lot of folks in the room, this is going to be, you're going to be very familiar with this. And for other folks, it might be all new. So I'm trying to strike that balance there. We'll highlight what it means to be a classic psychedelic. That's really what we're going to talk about, the classic psychedelics, what's an enactogen or an empathogen, and dissociative substances. We're going to really have a fun trip down the journey of history, the history of psychedelics up till from the beginning until kind of now. We'll talk about the now, the psychedelic renaissance, as some people have coined the what's happening in research. And we'll talk briefly about what a psychedelic session may look like in a formalized therapeutic environment. And we'll talk about a few challenges with using psychedelic substances in a medical or therapeutic model. And then we'll talk about some future research directions. So the psychedelics, here are a few definitions. So psychomimetic, as we all know, is a drug or substance that produces psychological or behavioral changes resembling those of psychosis. Then what is a mind-altering substance? And this is sort of like conversion disorder, where there are a lot of different names and there's overlap and renaming and refining naming and nomenclature. So mind-altering substance is something that changes a mood or perception. A psychosis inducer is a substance that produces psychosis. And entheogen, this is a word that some people may not have heard before, is a substance typically of plant origin that is ingested to produce a non-ordinary state of consciousness for religious or spiritual purposes. And so you'll hear me use that phrase, non-ordinary state of consciousness. If you get really interested in this subject and you start to read about it, you'll hear that non-ordinary state of consciousness. And it's exactly what it sounds like. When we are not in our normal state of consciousness, we are in a different space, perhaps with those open doors of perception that Aldous Huxley referenced, where we have a softening of ego potentially, and a softening of default mode, and we'll talk about that really briefly, so that we can experience reality differently. So these are the slides that I rearranged from the kind of middle to end to now. I thought, let's just go ahead and explain which are which, and then we'll drive and dive down into the history. So classic psychedelics, these are LSD, psilocybin, DMT. These are serotonergic hallucinogens. They're full or partial agonists, or both, of the 5-HT2A receptors, and they induce a state of altered perceptions, thoughts, and feelings. And this is just a cute little picture of psilocybin. Notably, the psilocybin that's being examined and studied is actually synthetic, not from the mushrooms. So what's used in communities is likely not what's being studied. What's being studied again is a synthetic. LSD, lysergic acid diethylamide, and that's this cute little drawing here. Interestingly, there seems to be a little less risk of serotonin syndrome. So let's say you had a patient who is taking sertraline. There seems to be a little less of risk of serotonin syndrome with psilocybin. I'm not exactly sure why that is. The empathogens, the enactogens, an example of this is MDMA. Used to be called ecstasy, and certain places still called ecstasy. You may hear it called Molly. MDMA is mixed serotonin and dopamine reuptake inhibitor and releaser. And so it's got a stimulant effect and induces a sense of emotional connectivity and increased sociability. MDMA is the focus of much study of MAPS, and we'll talk about MAPS. It's an organization, we'll talk about that a little later, that really has spearheaded studying MDMA in PTSD. And it's very probable that MDMA will actually be prescribable starting in 2024. So that group is working to train up in their protocol therapists who are guides for a therapeutic journey with patients. And then dissociatives. We're not really going to talk about ketamine today. So ketamine isn't truly a psychedelic, although it's often lumped into this group, and actually is already prescribed for depression. And there are ketamine treatment centers here in Boise that people can receive either an infusion or Spiriva and esketamine. So this dissociatives have been used for a long time as anesthetics, so especially in children. This reduces excitation, causes sedation, and some perceptual disturbance. And overly simplified, there's antagonism at the NMDA receptor, leading to an increase in glutamate in the prefrontal cortex. So this, I'm giving you all that we're going to really get about ketamine right here in this slide. And then a glutamate cascade stimulates, and you can see that in this cute little cartoon. Hopefully it's moving for you. It's moving for me. So you get a glutamate cascade. It stimulates receptors downstream that can then increase expression of synaptic proteins, leading to remodeling and really then increase synaptic plasticity. And that's really, truly about as sciencey as we're going to get today, I think. So what's a little bit about the history? So we know that, and did I skip something? I did not, okay. All right, so history, we know that peyote and other substances have been used for a really long time. There's evidence of use of substances for ritual purposes in ancient times. There's current indigenous use as well. Then the early, and we'll actually walk through a real timeline. This is just the highlights. So early science with looking at LSD in the 1800s, really all the way till the 1960s. And then what could be called prohibition, when rules and regulations were changed. And so all study ceased to be allowable, and use was no longer allowable. And then that's probably the late 1960s to 80s. And then a renaissance from the 80s until present. Yeah. So what kind of use was there in ancient times, and what does the indigenous use look like? So this is dried cactus at the top, and then this is a San Pedro cactus. Mescaline is what is the substance that comes from the cactus. It could be a peyote cactus. So evidence points to the use of psychedelic plants as early as 3500 BCE. Traditional uses were tied to religious ceremonies, used for pain, and used to prepare for battle. And when I think of this, and I think of kind of the images of counterculture that many people may associate with psychedelic use, it's really hard to reconcile unless we remember that when these plant medicines were used and are used in religious ceremonies, they're treated with a reverence, and they are, it's a very serious ceremony that with you can actually go and seek out these ceremonies now, by the way, but it wasn't what we think of when we think of the kind of current counter, or even the counterculture of the 60s, 70s, and on. This is a very kind of inward ceremony of focus and discovery. So cacti, including peyote, San Pedro, and Peruvian torch, contain mescaline, which I just mentioned, which can be dried and smoked or infused into water, can be made into mezcal in alcohol. I actually was at a dinner recently, and someone asked the server what mezcal was, and I didn't volunteer what this is, but I'm not sure. It must have been on the menu. There was something that sparked the name mezcal was on the menu. So psilocybin is a mushroom that is native to Americas, ingested through chewing. You can create a tea to treat pain and to participate in ceremonies. Cannabis was often used in, or thought to be used throughout, history. obviously from the marijuana plant, has milder psychedelic properties. Ayahuasca, that's the brew. We saw the pretty picture with the leaves on the bark. Made from plants in the Amazon rainforest, and that has the potent psychedelic DMT in it. And then salvia, I showed you the picture of the salvia plant, which is a dissociative. You can smoke or chew it, make that into a tea, but you don't do that. People can. Okay, so moving on into the early science phase of the history of psychedelics in human use and into psychiatry. So in 1895, there was the first trial involving peyote in Washington, D.C., now at which is now George Washington University. 1912, Anton Kolich, a German chemist, became the first person to synthesize MDMA. That's ecstasy, the cute little pills that look like Smarties. Ernst Spath in 1919 synthesized mescaline. Then in 1931, we had Richard Mansk, a Canadian chemist, who was the first to synthesize DMT. 1938 really is when things start to shift pretty significantly. So in 1938, a Swiss chemist named Albert Hofmann created LSD. And by 1943, he self-administered LSD. And he started to publish on methodologies and findings. And that, so April 19th, 1943, Hofmann took what he thought was a really tiny dose of LSD that he had synthesized in his lab. I think it was 250 micrograms, something insanely huge in the LSD world, if such a world exists, in dosing anyway. And so he had the most interesting bicycle ride home that day. And it's well documented. It's a well documented ride. And in some places, April 19th is considered bicycle day. It's a holiday. Everyone rides their bike. So he was not expecting what happened to happen. So he gets on his bike and the LSD starts to work. And he wrote about his experience in a memoir, LSD, My Problem Child. And this is what he says: kaleidoscope, fantastic images burst in upon me, alternating, variegated, opening, then closing themselves in circles and spirals, exploding in colored fountains, rearranging and hybridizing themselves in a constant flux. And so that's a picture of Albert Hofmann. He was so taken by his experience that when he was working with Sandoz Laboratories, they started marketing LSD and distributing it to psychiatrists to study the effects on mental disorders. And it was sent far and wide. Anyone and that he could find who would try it out, try it with his patients, and document the findings was considered, more data points. And yeah, so in 1958, he isolated and figured out the structure of psilocybin and psilocin. 1960s, Stanislav Grof carried out more than 4,000 LSD-assisted therapy sessions, and we'll talk about him in a minute. This work was huge. Stanislav Grof's work in therapy and changing kind of the face of psychotherapy. But then in 1966, we have a ban on manufacturing and sales of peyote, mescaline, LSD, and DMT in the US. 1968, we have a ban on the personal use or possession for any reason. And in 1970, we see the Controlled Substances Act with the schedules come on the scene. So to drill into the history of LSD itself, like I said, Albert Hofmann synthesized the LSD, searching for an ergot alkaloid useful for medicinal purposes. He used it on himself in 1943. Then Sandoz Laboratories began producing it in 1947, 1950s. The CIA actually started Project MK Ultra, where they administered LSD to subjects to monitor their response. So people who were included were military personnel, government agents, physicians, the mentally ill, prostitutes, even the general public. And in 1963, the Sandoz patent expired. The US in the same year classified LSD as an investigational drug. That created restrictions on the medical and scientific use of LSD and really limited study. By 1968, as I said, possession became illegal and there was a complete research ban, with the Controlled Substances Act appearing in the 70s. So prior to this 1968, that psychedelic research was really ramping up, with Timothy Leary doing research. Richard Alpert, who you may know as Ram Dass, was studying LSD and psychedelics, and Alan Watts. All of them were really vocal advocates. Psychiatrists and other scientists really were studying LSD until that kind of demarcation in 1968. For the treatment of many conditions, including mood disorders, substance use disorders, and psychotic disorders. Some of the really early work with LSD was for alcohol use disorder, or what was known as alcoholism at the time, obviously. And some of the studies that the psychiatrists and the psychologists did, including Stan Grof, whom I mentioned a minute ago, were in those mystical states and these altered consciousness, or altered states of consciousness, non-ordinary states of consciousness, if you will. So let's talk about what a Schedule I substance is and why this really brought everything, all the study and work to date, to a halt. So substance that's Schedule I has 3 criteria. It's deemed to have a high abuse potential. It has no legitimate medical use and treatment, and there is a lack of accepted safety for its use under medical supervision. So this is a picture of a distinguished professor at Indiana University School of Medicine. He's been considered the foremost authority on chemistry and pharmacology of psychedelics. His name's Dave Nichols. Dr. Dave Nichols. And so what he has to say about this is the DEA's definition for high potential for abuse really means that people will take it without a prescription. Doesn't necessarily mean that it has a high possibility of people getting addicted. So what he's saying, the way I read that, is despite the criteria, what it's really saying is we don't want people to take this on their own. We don't like it when people take it on their own. And by take it on your own, we're going to say high abuse potential. But I think those in the addiction world might not agree that that is how we would define abuse potential. So what really happened? What happened there? So before LSD was banned, the NIH was funding more than 130 studies into the use of LSD, like I said, for anxiety, depression, alcohol use. And this led to a rapid increase in brain science, a rapid increase in the knowledge of the brain and brain science, how the brain works, how we respond to things. And at the same time, there was an adoption by the public of recreational use and an association with Vietnam era anti-war sentiments. This led to fear, and in an altered political landscape, an ultimate banning of further study. So there was so much enthusiasm and excitement about these substances, it really went into the counterculture where people could share and access these substances outside of any medical study. And it really blew things up, if you will. And I think that's a real risk of this new renaissance, although the public sentiment is quite different at this time about research. This is an actual ad. Taking a trip, go LSD, the only way to fly. See your travel agent. Now, like I said earlier, you can Google, you know, spiritual guide or something like that, and you can find folks who will, for a sum of money, and usually they're tiered. You can get like the basic plan, or you can get the premium plan, and your guide will guide you through your journey. That's not what we're hoping to do with the research, and applying it to therapeutic settings. Obviously, we want to take the science as it's discovered and apply it in a way that brings benefit to patients in a safer environment that has, you know, a trained guide and a trained psychiatrist or other qualified person to help them, and then follow through with what's called integration at the end. So let's talk about, going back to our timeline now, of psychedelics renaissance. And oh, I should try to figure out how much time I have. Okay, I think it's 12:35. So the psychedelic renaissance timeline. So what's happening now? So through the efforts of a dedicated few early on, the way has really been paved for resurrection of psychedelic study and renaissance. So in 1998, Franz Vollenweider discovered that LSD and psilocybin bind that 5-HT2A receptor. 1999, Roland Griffiths, who is a really big name and in psychedelic science, he's at Johns Hopkins. He and some of these few others have really advanced the knowledge. So he establishes his research at Johns Hopkins to study the effects of psilocybin. He publishes a paper showing that psilocybin can induce mystical experiences, and there's actually a mystical experiences scale. You can Google it. Robin Carhart Harris started studying psilocybin in the UK in 2009. Charles Grob published his research on psilocybin, reducing anxiety in cancer patients. Oh, sorry about that. Another group demonstrated with imaging that psilocybin, and we'll actually take a look at that, psilocybin increased neuronal connectivity, and I'll show you a really cool picture. Robin Carhart Harris was involved in that as well. He published on LSD increasing connectivity. There was a study then that showed ayahuasca led to a significant decrease in depression symptoms. By 2019, the Imperial College of London launched their Center for Psychedelic Studies. And then in the same year, Hopkins launched their Center for Psychedelic and Consciousness Research. Both centers research what psychedelics reveal about consciousness and how these compounds can help treat things, again, like depression, anxiety, addiction, and PTSD. So more specifically, Roland Griffiths discovered that a dose of psilocybin led to enduring improved mood and a sense of well-being when administered therapeutically. This neuroimaging with studies from Carhart Harris and Nutt showed that psilocybin dosing produced alterations in brain functioning, particularly in the default mode network. So in this particular picture, which is really kind of neat, what you're looking at is what's considered a neuronal scaffolding. And so the picture with the less lines, less color, less density is kind of resting state or placebo. And when a patient takes psilocybin, for example, LSD, for example, these more lines. So you see more lines, thicker lines, and larger nodes, these little circle things. And all of this points to increased connectivity in brain areas that maybe previously were not connected. And the fascinating thing about this increased connectivity is that it's enduring. So not only do we have more lines, bigger nodes, we have darker and thicker lines, and those indicate, even in areas where there are already connections, the connection's stronger in some instances. And so what we see is there's just increased integration in between cortical areas. So these types of studies paved the way for further investigation into depression and all the things I've said 10 times. And for a likely future state, we'll have licensing for medicinal use and approved diagnosis. Having said that, Oregon and Colorado both have legal use of psilocybin. In Oregon in particular, there were challenges, it seems, with making them, prescribing them and associating it with a diagnosis. So in Oregon, psilocybin use will be for, I think it's called for supported use. It's not associated with a diagnosis. It's not necessarily medicinal. So I'm sure there'll be more to come on that. What are the studies looking like? How much has this ramped up? So we can just take a look here. In 2010, we see there were 3 studies on MDMA, and then all the way up to, we get to 2020. And so you can see the gray boxes are psilocybin, the orange is MDMA, and blue is LSD. I think there's a little less inclination to study LSD now that psilocybin is being studied more because of the duration. A psilocybin experience will last 4 to 6 hours with an onset in maybe 20 minutes after dosing. An LSD experience will last potentially 20, even longer, 20, 24 hours. The onset of starting effect would be maybe 45 minutes to an hour. And you know, if you're going to already do something that requires potentially even 2 therapists and 1 patient at a time, 4 to 6 hours is a really long duration already. And so it would be really impossible to have that, 24-hour therapy session, if you will. So I think we'll see more and more studies of psilocybin and less, as you see here, not much of LSD. So by 2020, and we know what happened in 2019, 2020, we're up to 17 trials. Countless phase 1 and phase 2 studies are happening around the world, including the US, Israel, England, Europe, Australia. Let's see, it's 12:42. I'm gonna not go into all of this, but you'll have it. Sorry if it's too small though. This will explain the different, the derivative, so the substance, the derivative or chemical analog, and then you'll see the general effects, potential harms, and potential therapeutic uses. Suffice it to say that the first 1, 2, 3, 4 are going to work at the 5-HT2A receptor, and so they're going to have a very similar effects and properties and very similar potential harms. Potential harms, of course, being psychosis, persistent hallucinant, so what's called a hallucinogen persisting perception disorder. That could be anything from, maybe you've heard of something called trailers, where if you've had an LSD or a psilocybin experience, you may see trailers from your, your line of sight, all the way to flashbacks. So not particularly common, but those are risks. And then the potential therapeutic uses here, all the things we've been talking about. There's actually an interesting study with psilocybin and Alzheimer's happening at Johns Hopkins currently. And even though folks in the study may not remember their life history so well, the study group, as opposed to the placebo group, does report feeling better overall, less depressed. So these are some of the indications under evaluation by substance. So ayahuasca is being studied for depression, substance use disorder, PTSD, all the way to psilocybin being looked at for most things. This is just to show you there are so many studies happening right now. You know, we're studying, Marina is studying OCD, Johnson's studying tobacco dependence, and on and on. We've got Carhart Harris, very active, studying resistant depression. Rob was studying cancer and acute stress. So there you have that. Lots of studies. And then I wanted to just read you this book excerpt. Oh, and I realized I didn't really talk too much about the default mode network, so we'll talk about that as well. Well, maybe, and I'll just say it before we read this book excerpt. So one way of thinking is, so often people ask, well, how do these work? How do these work? How do these work? In order for a drug to be approved for prescribing, we don't actually have to know how it works, right? We don't know much about how things really work in psychiatry. We know some, but not as much as we'd like to know. But what we do need to know is that something's safe and has therapeutic benefit. So but regardless of that, we kind of are interested, right? How do these things work? How do these things work? So we know that we have increased connectivity from parts of the brain to others that wouldn't have been engaged potentially. And then there's this idea of the default mode network. And this is going to be really an oversimplification. There's a fair amount of study happening about the default mode network. And so certainly I don't know all the things that the default mode network is responsible for, but very simplistically, we can think of, you've all heard of mindfulness. So the mindless self, kind of our autopilot, it can be conceptualized as the default mode network, kind of our resting state where we are all the time without, you know, it's our automatic thoughts. It's kind of just our autopilot. And there's some thinking that these substances help keep us out of the default mode network and soften our ego. So that's all I wanted to say about default mode network. That's probably a whole scientific talk that we'll have to leave to someone else. So this is a book excerpt. It's a really great book. If you can read it, I highly recommend it. I reached out to Dr. Miller to ask if I could read from his book to you, and he was just thrilled that I was going to be talking about him at our talk. And so he says, I received my first license to practice clinical psychology in 1966 while teaching psychology at the University of Michigan in Ann Arbor. One evening, a colleague invited me to his home where he offered me the opportunity to experience DMT. I took one puff off the normal appearing cigarette, immediately closed my eyes, lay back, and explored the very deepest core of my consciousness and the very borders of the universe. I had a clear sense that within the infinite universe, I was smaller than what I see while using an electron microscope. I experienced being and nothingness, that dissolution of ego, if you will. The experience lasted about 12 minutes. I sat up and asked for another puff. Once again, I embarked on inner space travel. I became a dematerialized inner space traveler, transcending time. I soared through the universe in search of the source. I had a clear sense that I was a part of and an expression of, whole of it all. My journey had begun. And I read this to you. This sounds like a psychedelic journey, but I read this to you because it does get to the core of how we think these substances work. And I mentioned this in the very beginning, and why there's this sense that psychedelics may be the bridge between the medicine of psychiatry and psychotherapy. The idea being that if I am less attached to my own ideas, myself, my automatic thoughts, things that keep me stuck, that I may be able to experience my reality differently. We know that some of these substances quiet down ruminative areas of the brain that we see in depression and anxiety. And so if I can experience my world, my thoughts, and in some ways dissolve some of my preconceived notions, if you will, I may see my world and experiences quite differently. And these substances seem to have, some of them, in particular psilocybin, a durable impact, meaning that someone does not need to be taking psilocybin every day like an SSRI. People in the studies frequently will no longer require their medications. Of course, they've had to stop the medications to participate in the studies, but they don't resume them. So that's enough about that. Enough said. I mentioned MAPS. This is the psychedelic, oh my goodness, I almost got ahead of myself. The Multidisciplinary Association for Psychedelic Studies. They're actually having a conference in Denver in June. Should be pretty interesting. It's a little on the expensive side, I thought, for my blood, but I would have loved to have been able to go. You can Google it. I think it's just called Psychedelic Science 2023. But this group has really been at the forefront of the MDMA studies. I mentioned that earlier, using MDMA for PTSD in particular. It is very likely that MDMA will be prescribable in the very near future. In anticipation of that, this group is training psychotherapists to be ready to do MDMA-assisted psychotherapy. So it's a really interesting group. They're doing really interesting work. You can sign up to get their daily emails. And we're coming toward the end here, I think. What would a session look like, for example? So this could be a psilocybin session. That's Anderson Cooper, in case any of you were wondering. You can watch parts of this on the news, I think, or from CBS News. So typically what will happen is, let's say someone's going to have a psilocybin session, and that's what they're preparing for. They'll meet with a therapist first, and with a trained therapist, could be they're meeting with a psychiatrist, and the therapist is known as a guide. They're told what to expect to some extent, and they problem solve in this first session not only what they may expect, but if there is fear or anxiety or a bad trip, if you will, if something bad happens, kind of making an action plan to address that. And then in the session, the patient might be offered eye shades and headphones with maybe music compiled in advance. There's actually a really great Spotify playlist from Johns Hopkins, and I think it's called Psychedelic Session. You can look for it, or if you email me, I'll find it and send it to you. The psilocybin session may last 4 to 5 hours. The guide is really just, they're not there. It's not like a typical therapy session. The guide is there for reassurance. They're there to be a presence, a supportive person. But the patient's not really expected to engage significantly with the therapist in the moment. patients will often have those inner journeys like I've described that we see in the literature. And then after the session, the patient will return for what's called an integration, where they can talk through the experience and integrate what occurred. And then in that moment, they will create a plan for ongoing psychotherapy. So what are some of the challenges with this? Well, as you can imagine, there are a lot of challenges and there's a lot of questions to be answered. Substances are highly regulated. Right now, they're scheduled as dangerous illegal drugs. And so that's something that has to be addressed and navigated. Knowing how in the world could we train enough therapists to act as guides if this is a one-on-one, and sometimes even two therapists on one patient. And you might wonder, why would you ever have two therapists? The idea is that if you're in a room for a long time with someone, if you have to step out, you don't want the patient to have to be alone, and frankly, two people safeguards against anything kind of unorthodox or unsavory going on. Not that we would anticipate that, but you would want to safeguard against that. How do you ensure fidelity to good practice? Through structured manualized treatment. How do you keep patients safe from those who might be out in the community taking advantage of the next best thing without adequate training and knowledge? Really, even people who think they're doing good, solid work, but are a little laissez-faire with the treatment approach. And then what is the necessary treatment and knowledge? And how do you monitor outcomes in a non-study environment? What do we do to prevent another prohibition if these substances become really commonly used and freely found in the world? Then that could invoke a significant amount of fear, like happened and led to the cessation of study in the 60s. And maybe you've identified other challenges. What are some future research directions? What are some questions? So we want to understand, can psychedelics provide therapeutic effects without the trip? Meaning, can the hallucinogenic and mind-altering properties be disentangled from the inner journey? Or is it the inner journey that provides the therapeutic benefit? We want to know, how does this really work? We want to understand, what is consciousness and what in the world is reality? Is it the construct as Aldous Huxley described? Is it something else? And then what I really want to know, and I think what many of us want to know in psychiatry and in psychology, is how does my view of the world inform my response to it? And what can I do about it? Or what should I do? Or should I do anything about it? And I'll leave you with this from Stanislav Grof. Consciousness does not just passively reflect the objective material world. It plays an active role in creating reality itself. And that is all I have for you. Thank you so much. Here are far too many resources and references for you. Thank you.
Thank you, Dr. Fox. We appreciate giving your talk today.
Do we have any questions? Let's see, I can't even really see the chat.
There's been quite a bit of activity in the chat, mostly around your suggestion. I don't see any questions, but
okay.
I welcome anybody to come off mute if they have questions.
Oh, this is great. I love this. We should capture this somehow, this chat.
Yeah.
Dr. Fox,
Yes.
I just want to say thank you. It's very helpful for me to break down my own barriers of prejudice about this. So I'm opening, you're opening up some new vantage points for me. So thank you. It's excellent.
Thank you.
I'm noticing there's a similarity between the assumption of the uninhibited human without blocks with what Carl Rogers posited with client-centered person therapy. If we can just remove some of the obstacles, there's a presumption that the human spirit will find ways that would be useful. And I'm just thinking of that the psilocybin-associated psychotherapy, the same philosophy is there, that the person who is guiding is not doing a lot of intervention, as I'm hearing you share, but the act of the medication, making connections and breaking down walls itself presumes that the human, a very positive, growth-oriented impulse humans might have. So I just think that that's kind of interesting from two similar assumptions with different, one with therapy, one with kind of a biology emphasis.
Yeah, you actually are hitting the nail on the head. There's some thought that these substances catalyze exactly what you're talking about. They serve as a catalyst. So rather than, every week having a psychotherapy session for 5 years, that somehow those same changes that can be catalyzed by therapy over years can be catalyzed with one dose of psilocybin, maybe a follow-up dose in 3 months. So you're exactly spot on. That's the idea.
Thank you.
Yeah.
Right. I mean, that's the idea. I have to metabolize my skepticism, but I'm just noticing the similarity there, which I think is kind of a reaccrediting of the view that there's a positive human-centered element to this. So thank you very much. Appreciate it.
Yeah, thank you. What other questions do we have? And I will say, if anyone's thinking of a question, please ask. Part of this is why doing psychedelic assisted psychotherapy in what I maybe would call an official therapeutic setting, you need to set the stage, you set the frame, you have a controlled environment. The idea is to optimize the outcome for the patient, which is radically different than recreational use. And I'm not here to talk about recreational use. I'm not here to make any kind of judgments about recreational use, but it is different. People do say, hey, if I took mushrooms and I felt better. That's a really different type of experience than what we're talking about here, which is intended to be in a controlled therapeutic environment with a therapist or guide, whose official role is to be a guide, not, your friend Joe from the dorm room down. No bashing on Joe, but that's not our focus here in psychiatry. What other questions?
Looks like Dr. Hansen had a question in the chat. First, thank you for a great presentation. Does this research direction change how we think of and treat schizophrenia, given the similarities in psychotic experiences?
Well, so the original work around LSD was, some of it was in attempting to understand what it was like to be a patient with schizophrenia. I don't know the answer to your question. I think it's a really good question. The question has come up, is someone who's predisposed to schizophrenia automatically, not a good patient for this? I don't know the answer to that either. Mania has been an exemption for study in most of these, having had mania in these studies, but I don't know if it changed. I guess if your question is, does it change our perception of schizophrenia? I think that it might give some insight, but it's going to sound weird, but it's almost like when I wonder if someone else sees orange the same way I see orange. I wouldn't know if the psychedelic experience I'm having is similar or dissimilar to someone with schizophrenia having not had it. I can make those maybe some leaps, but I'm really not sure. So I'm not sure that I know the answer to your question. I think it's a really interesting question though, and would make an excellent grand rounds. And if someone in the group knows the answer to some question, I am just an interested student in psychedelics and psychiatry. So there could be someone out there in this group who really is similarly interested and has, thought about this more and read more. So please chime in if you have answers to questions. Well, I don't have anything else for you, but I do want to read the chat because it's so nice to see everyone's participation and engagement. So thanks for having me. And you can all, I think you probably all have my contact information. So if questions come up or you have ideas and you wanted to explore them, reach out anytime. I'm here.